Hello, everyone. It's great to be able to be with you today. Even though we're virtual, I feel like we are really together, and I hope you're going to enjoy what I'm going to talk to you about. My name is Dr. Cathy Raggio. I am an orthopedic surgeon, and I work in New York City at Hospital for Special Surgery. I run a skeletal dysplasia center, and today I've been asked by the group to talk to you about orthopedic considerations and the pros and cons of joint surgery. I added in the title, What Do We Know? Because you're going to be surprised about how little we know. So even though I'm not going to give you maybe a lot of facts, I hope to be able to give you a lot of good roadmap work so that you will have some good questions to ask your doctors and questions to ask yourself if you're looking towards having some orthopedic procedure done. So before we start, as always, these are my disclosures. And the only one that's really relevant for today is that I am on the board of the EDS Foundation. So in order to address the question, what are the pros and cons of joint surgery? I think we want to divide it into two parts. Number one is, what do we know? Number two is, how can we make an informed decision? And so let us start. What do we know? So what do we have to know to make a decision? First of all, we have to know who is at risk for needing joint surgery. The second thing we have to know is, what the heck is a joint? What is she talking about? What is joint surgery? And the last thing is, what have we learned, or what do we know from the literature? That is where people write about patient experiences, people write about surgeries they've done. What do we really know? So we're going to address all three parts of this in the first section of what do we know and what should we know. So the who has EDS is going to have orthopedic involvement. Well, most of you, I think, probably know the answer to this. It's most of people with Ehlers-Danlos syndrome will have some form of an orthopedic component to it. And if we really look at it and break it out, 9 out of the 13 types have orthopedic components. Most, it's hypermobility, and you all know the hypermobility scale. You've probably seen this already. If not today, you've seen this before, of how we measure hypermobility. So that's what we're talking about. And here are the types of EDS that have orthopedic involvement from 2 articles. And we know classical-like, cardiovalvular, and onwards down as we see. And many of them are named because they involve the joints. These joints, spine, muscle, spine again. So these are not surprising that they would have orthopedic involvement. We also know that the hypermobile EDS, which 90% of all EDS patients have hypermobile. So this large group up here is really only 10% of all people with EDS. 90% of people with EDS fall into the hypermobile group. And yes, indeed, they do have orthopedic involvement. So we're going to really focus on that as we go forward. Now, the next question that I talked to you about is, what is a joint? And I always like to include this because I feel it's very important that we know the dictionary of what we're speaking of. So a joint is really 2 bones, very simply stated, that are held together by ligaments. So this is just a picture. It's an example of a joint. It happens to be a shoulder joint. So 2 bones. So here's the end of the humerus. Here's the clavicle. Here's the scapula. So we have 3 bones that can come together, but 2 bones can be held together by ligaments. So ligaments are what hold bone to bone. They connect from bone over to bone. With tendons. So this is a tendon. Tendon is the end of a muscle. So you have muscles that go into tendons. Tendons then insert into joints. They can insert into the bone themselves. And so what happens is when the muscle contracts, this tendon pulls and allows this bone to move, and so the joint moves. There also is this green thing inside, which is called a capsule, and that has fluid that keeps the joint very lubricated. So again, when you talk about you need joint surgery, the question is, do you need surgery that's going to involve more of the bone? Do you need surgery that's going to address more capsule because that has stretched out over time? Do you need surgery that's going to involve the ligaments that surround the ligaments from bone to bone that surround it that are also stretched out? Or is it a problem that your tendons coming in are frayed? They're getting frayed because of bone hitting on them, or they're frayed, or they're weak because the muscle is weak. So again, important, and we'll come back to this at the end, that you need to know what are you talking about when you speak about I'm having joint surgery. Now, as you all know, joints are everywhere. There are your hips, your knees, your hands, and your feet, your ankles, your shoulders, your elbows, your jaw, in your spine. And we have joints that move. So your shoulder moves a lot. And you have joints that don't move very much or shouldn't move very much, like your SI joints. And if they move a lot in certain conditions, that might be a problem. So you want to think about, what joint am I talking about? Is it one that should have a lot of motion or not have a lot of motion? Is it one that moves in multi-directional, like in circles, like your shoulder? Or is it a joint that should just move in one plane, like the knee? So these are important things to understand because they're going to inform you in how to ask questions of your doctor and get answers. So we've gone through two things: who's at risk that need joint surgery, which are many, many people are at risk from maybe needing it. Number two, we talk about what is the joint, so we know what part of it we're talking about. And the third component to this of what do we know is, what does the literature tell us? And it tells us very little, actually. There is a paucity of knowledge in the literature that is scientifically vetted. And what that means is literature has to stand up to a certain standard if it's a scientific writing. And there's very little good scientific writing. And why is this? Well, one, for EDS, there was not a very good classification system previously to the early and mid-teens of 2014, 2015, 16, and on. We didn't have good classification systems. So everybody was lumped into one group if you were going to talk about someone. The other thing is, you don't have a good classification system. How do you know what surgery works on whom? And so you need to be able to classify people in order to report, this is a good surgery for this class of problem or that class of problem. The second thing is, that ties into this, there were no good standards for accurate reporting. So normally now what we'll say we need to know preoperatively, before your surgery, what is your actual range of motion? What is your Beighton score? And we have to have very accurate ways of doing this so that after surgery we can compare. So we're now in the process of getting those standards together for EDS. And the third reason why there's not a lot of great literature is surgery is often not the best course of treatment for people with EDS. So I think that might be a good sign that there's not a lot of surgery going on when we don't necessarily think it shouldn't be the first course of action. So I think that's a positive from this. But if we do look at the literature, what do we see? Well, there's a lot of patient reports. Patients say, I feel better, I don't feel better. And that's not, even though it's important to know that's a patient-reported outcome, it's not the full scientific basis of, is this the right surgery for this person necessarily? And often with the patient reports, we don't get a lot of preoperative range of motion and postoperative. So it has some merit, but it's not a strongly vetted merit. There are some papers out there that have techniques in them. And then there's a paper that came out that said that about 34% of people who had surgery had some positive outcomes. So that wasn't so great. And so what we did at my institution, we looked, and this is some data now that's going to be published. What we did is we said, let's look at everybody who had surgery, who has the diagnosis of EDS, and let's go back, which is called retrospective, and look at what results we saw. So can we then, by looking backward, inform the future? By looking at this data, can I come up with, gee, this is a better way of doing it. This is a person we should do this and we shouldn't do this in. And so what we did is we looked back and we focused very strongly on around the operation. Preoperatively, what did the patient tell us? What did we do intraoperatively? Were there complications? And post-op, were there complications? How did that look? And so let me show you that. And so we had 120 people, mainly female, as you see, 111, and 9 males, and that's not surprising with the EDS breakdown. The average age at surgery was 38, but we had a large range from 7.6 to 83.3 years. And on these 120 individuals, there were 240 surgeries performed with at least a 2-year follow-up. And that's important because in our orthopedic literature, 2-year follow-up is considered the gold standard in order to report on patient outcomes. So the take-home message here is right here in blue, that 91% of the surgeries that were done had some complication. And of those, about 120, a little over half, required more surgery. So that makes you pause. It makes you say, why so many complications? What's going on? And what were the complications we saw? And what we saw were persistent pain, continued subluxation dislocation, instability of joints that weren't there before in the same plane, hardware pain. So we put in hardware to help hold the bone in place, and people complained of pain from that. Infection and revision. And the revisions we talked about, that means going back to surgery. And so most of the surgeries were done, you might be thinking, what parts of the body were this? Well, the most common was hip, then we had spine, knee, and foot. Those are the most common. We also had hand and wrist, but in order going downward, as I told you. So what does this mean? Does it mean that, gee, wrong surgery, wrong patient, wrong doctor? No. We have to look at inherent causes. So does it mean that when you have EDS, you inherently are more prone towards complications because perhaps your tissues, what we have to operate with and on, are different? They don't heal as well. They don't respond as well. Is it that we need to address, as we talked about when we look at joints, are we addressing the correct part of the joint that needs treatment? And also we're looking at things external, meaning maybe it's not just the surgery, but perhaps there wasn't enough prehabilitation before surgery to make the muscles strong to help the surgery afterwards. Like I showed you on that slide, you need to have the muscles be strong. Perhaps the muscles were not balanced. That's often what I see, is that people are not, that they're not weak, they're just out of balance. One muscle group is too strong and another group is too weak. So perhaps that wasn't addressed either preoperatively or postoperatively. And I see a lot of people postoperatively who've had surgery, and they're sent to me by the surgeons to say, gee, this person has EDS, but they don't seem to be doing as well as we would think. And generally what I find is people are out of balance with their muscles. And I think that that's going to be so important. And I'm going to come back to that point again as we go on. So I don't think we need to throw out the word surgery with EDS, but I think we need to look at this cautiously. And so that leads us to the point that I think you all are here to listen to, is how to make an informed decision about, is this going to be a reasonable surgery for me? And so I always tell everybody, what's the biggest pro for surgery or for anything? is the benefits must outweigh the risks, and then that becomes a pro. In order to do that, it's an individual decision, which means it's individual for you to say, in my life, at the point I'm at, what I have done, I feel that this is the right decision to make. And I'm going to take you on the next slide into how you're going to, what questions you're going to ask to know it's the right decision for you. And the next thing for individual, it's got to be individual for that joint. Because you had a successful shoulder surgery doesn't necessarily mean you're going to have a successful knee surgery. You want to address each joint separately. Remember, one size fits no one. That's so important. So you want to be informed. And so this is really the heart of the matter. If you've fallen asleep from everything else I've said, which hopefully you haven't, but if you have, this slide you want to wake up for. This is how to tilt the balance of risk versus benefit in your favor. So these are the things you need to ask yourself and have answers to, ask your doctor and have answers to, ask your physical therapist, ask people that are helping you get better. 1, have you exhausted all non-surgical options? Physical therapy, bracing. Are you doing a daily exercise routine? Are you being faithful with that? Maybe you need to go to activity restriction. Maybe you can't play tennis overhand serve anymore. Maybe you just have to switch to a different way of serving. Would that help enough? Or is it so important that you're willing to go ahead with surgery just to try to see if you can get an overhand serve back? These are the benefits, these are the risks, and you need to think about it. 2, are you willing to commit to both prehabilitation? And that means before you have surgery, we generally like to do at least 6 weeks, especially with elective surgery. I'm talking this is elective, not emergency where you've fallen down and you must have surgery to fix something. But are you willing to commit to prehab? Doing 6 weeks of getting yourself in the best shape you can be, rebalancing those muscles to the best of your ability. And what people always focus on with prehab is, oh, I can't do anything for that joint. That's why I'm having the darn surgery, doctor. Well, I'm not really worried about the joint that I'm operating on 100%. I'm worried about the rest of your body. Because when you go to use your shoulder, like I'm using my shoulder, if I haven't stretched my neck out correctly, or I haven't strengthened my core correctly, then when I go to do my exercises afterwards, I'm going to have my neck over like this, and I'm trying to stretch my shoulder, and that's not going to work. And so it's really prehabbing your total body, not just the part that you're having surgery on. And that's the key, because people who do prehab on their legs, on their core, say, and they're having shoulder surgery, are so much stronger afterwards. Doing prehab on your legs and your arms before your spine surgery, so much better. So you want to be willing to commit to prehab and post-op rehab as prescribed and for the long haul. I tell people mostly you expect to get back to a 90% at 6 months after surgery, and hopefully you'll be at 100% at a year post-surgery. So that's what we're talking about. Next, what are the goals of surgery? So you want to know this going in. Are you going in for surgery because you want to be more stable? And does that mean, gosh, if I just dislocated once a day, I'd be happy? Or does it mean I never want to dislocate again? So you want to be realistic. Number 2, is it pain relief you're going in for? And lastly, as we talked about, what part of the joint is the problem? And so that you're directing your goals of surgery at the right part, and that you and your doctor are in sync. You might think the goals of surgery are, oh gosh, if my shoulder doesn't hurt, I'll be happy. Your doctor might think you want it to be stable, but still have some pain. So you need to talk about these things ahead of time. The next point is, what are the trade-offs that you have to give in order to get your goal? And what do I mean by that? Well, if you want it to be stable, you might have to give up some motion. You might be a little stiffer. you might have to restrict some of your activities. You need to decide this, because then you're going to make an informed decision about, this surgery is going to be good for me because here's my goal, here's the trade-off I know, and I'm willing to commit to the rehab I need before and after because I've exhausted all my options. And then lastly, you want to talk about, not lastly, but next to last, are you in the best medical shape? And how do you optimize your health? So again, remember, sometimes it's not the part we operate on that causes you a problem afterwards. It's the fact that, gee, you had a fracture. Why? Because your vitamin D level is low, you're osteoporotic. Gee, you're diabetic, your diabetes wasn't in good control, and so you don't heal well. Gee, you're malnourished, so you don't have enough protein to actually heal the tissues. So you want to be in the best medical shape. Again, this tilts the balance of benefit to you. And lastly then, have you gotten at least 2 opinions? And by getting them, have you listened to what the doctor said, written notes, and have you also had your questions answered? And I think if you've done all these things, I think then you can say, I think this joint surgery, whatever they've suggested to me, is going to benefit me because I know my goal, I know my trade-offs, I know my commitment to rehab, I know I'm in as good a shape as we can get me in, and I've listened and the doctors have listened to me. And so this brings us to getting your full evaluation, knowing your genetics, doing the targeted and the correct PT program and a home program, being realistic in your outcomes, and sharing that with the doctor, and doing a lifetime of exercise. For people with EDS, and most of us, it's like toothbrushing. We should do it twice a day. You should have an exercise program. You should be doing your closed chain exercises. Your goal is to create minimally flexed joints, never use full extension. Use your mirrors at home to gain perspective that you're standing correctly with your core always, always, always engaged, whether you stand or sit. And remember, it's low weights, high repetitions through limited joint motion. And I think these are some points I think you should take with you. I thank you for your attention, and I look forward to questions that we can go over today. And I hope this was helpful, and I hope we're all informed now and know the right questions to ask to get hopefully the right answers. Thanks so much, and have a great rest of conference.